So you'll have three potential management scenarios. A woman who presents with a history of prior genital HSV disease in pregnancy or labour. A woman who presents without a history of genital HSV disease with lesions either in pregnancy or in labour. So for all of your women who have known genital HSV disease, you need to counsel them about the very low risk of vertical transmission. There's no role for serial cultures. Consider for women who are having frequent symptomatic recurrences the use of suppressive therapy from 36 weeks gestation, and discuss delivery options. In general, we would recommend that at labour you have a careful speculum exam. If the rupture of membranes are less than 6 hours and there are no lesions visible, proceed to normal delivery, but don't use invasive obstetric procedures unless there was a clear obstetric indication. What about these women who have no prior history of genital herpes and present for the first time to you with genital lesions during pregnancy? Obviously, you would treat the woman for that lesion, but the most important thing is to characterise the type of infection by both vaginal swab, and here we would definitely recommend type-specific serology. It's important for us to counsel the risk of transmission to the newborn and how we manage the newborn. If the serology confirms that this is a reactivation, you would counsel and manage as for recurrent herpes. However, if the serology and culture indicated it was her first genital herpes, the way you would deal with that is potentially related to the gestation. According to Zanes-Brown's data, if she had her first attack very early on in pregnancy and you documented seroconversion, in theory you should be able to manage her for genital herpes. It's a pretty rare scenario. Most of the time it's later in pregnancy, we haven't documented seroconversion, so we'd then proceed to C-section. For all those women, avoid invasive monitoring and consider the use of suppressive antivirals from 36 weeks. What about the woman who presents intrapartum? Here, while statistically it's likely that she has recurrent genital herpes, we can't rule that out, and because of the high attack rate, we would strongly say perform a C-section to reduce the risk of vertical transmission. It's still important to perform type-specific serology and genital culture. That doesn't help you with the delivery management, but it does subsequently with the management of the newborn. Avoid invasive obstetric procedures and collect surface swabs on the infant, and here we would commence empiric antivirals on the infant because of the high attack rate. Now, there's no data to support that. Not everyone would do it, but that's the general consensus in the paediatric ID group. What of neonatal HSV disease? It's a devastating complication. It's uncommon. Our attack rate in Australia is about almost 4 per 100,000 live births, so we have about 10 to 12 cases a year. Importantly, in Australia, over 50% of the cases are due to HSV1, reflecting our increased genital HSV1 prevalence. And half of them will present with this localised disease to the skin, eye, mouth, but half will present with this devastating multi-organ disease. It's like a negative septic shock with a very high mortality and morbidity. The other important thing is 1 in 4 of these infants will die. It'll be that subgroup with the disseminated disease or the encephalitis often, despite the availability of antiviral therapy, often because the condition is diagnosed late. Again, we have 3 management scenarios for the newborn: those with suspicious signs, those infants born to women with active lesions at delivery, and those born to women with a history of recurrent disease but no lesions at delivery. Clearly, if an infant has signs, you must investigate and treat, and it's important to do that promptly, and the treatment is intravenous. There's no role for oral acyclovir in this setting. What investigations? You would do surface swabs, potentially cultural PCR. You need to do a lumbar puncture with HSV PCR to confirm or look for HSV encephalitis, because that influences both the prognosis and the duration of therapy. Central nervous system imaging and other bloods is listed here. So if your baby's delivered through an HSV infected birth canal, again, if you know mum has primary recurrent disease, it influences your management. If you don't know, you're going to have to investigate and treat. If mum has primary disease, you would commence empiric therapy. If mum has a history of genital herpes but no lesions, the risk to the infant is negligible, but you would educate the parents about signs of HSV disease. Some people in the past have recommended performing swabs on the infant at 24 hours to determine if they're infected. We don't generally do this. Iscyclovir is given at quite a high dose to the infant. This has been proven from retrospective cohort studies to reduce the risk of early CNS recurrence and the rate of dissemination. You give it 21 days if it's encephalitis or disseminated infection, or 14 days if it's localised disease. After they've had infection, there is a high risk of CNS sequelae, particularly in those with encephalitis or frequent HSV2 recurrences. Some individuals have tried to give oral acyclovir therapy to suppress those recurrences. We know that from phase 2 trials or phase 1 trials, that there is suppression of clinical recurrences, reduction of viral shedding, but we don't know yet any effect on long-term neurological morbidity. So, the most important message I can give to you is, if you have a woman with genital herpes during pregnancy with no prior history of genital herpes, make a definitive diagnosis of what type of herpes that is. If it's primary herpes, consider the very high attack rate to the newborn, and if a newborn has lesions of HSV, treat and investigate immediately. Just to let you know that ACID has a group of perinatal algorithms talking about management of a variety of infections in pregnancy, which Sue and a lot of other people have contributed to. Thank you.